cross-linking versus conventional cross-linking for keratoconus. I have no financial interest in this presentation. How do I move forward? I have no financial interest in this presentation. So first of all, why do we have to do customized cross-linking? Now, brilliant microscopy studies have shown that keratoconus could actually begin as a focal disease in the central or paracentral cornea, and actually outside the area of the cone, the brilliant shifts of a normal cornea resemble that of a keratoconic cornea. It is only within the region of the cone that the keratoconic cornea is actually weaker. And computational analysis has also shown that localized treatments for normalizing these KC corneas might actually help in selectively flattening the cone and thereby improving the visual function. So our purpose was to compare the outcomes of customized cross-linking with standard accelerated cross-linking in keratoconus. It was a prospective interventional comparative case series conducted at the Cornea Services of Eye Foundation, Coimbatore, between March 2017 till September 2018. This was all made possible by the advent of the CXL2 mosaic system, which allows us to do a tailor-made cross-linking where we can have broad beam and customized patterns available. This is also with the availability of an integrated eye tracking system, which actually enables us to ensure that this particular zone of cross-linking can be decentered to the location of the cone. We can select various patterns with different energies delivered in different patterns. For this particular study, we used concentric circles for the study itself. In terms of centration on how you're actually going to center these concentric circles, you could either do it on the curvature map or the thinnest zone of the pachymetry or on the posterior float. We chose the maximum of the posterior float because that is the only point which is not affected by the epithelial thickness, which we all know can be quite irregular in keratoconic corneas, and that does not alter in your maximum posterior float. So in methods, we use the standard epi-off mode in both the customized as well as the standard group. In the customized group, we treated 3 concentric zones of 3, 5, and 7 millimeter with an energy of 30 milliwatt per centimeter squared, which was delivered in a pulsed manner, and where the total energy delivered was 15 in the center, 10 in the 5 millimeter zone, and 5.4 joules per centimeter squared in the 7 millimeter zone. The standard cross-linking group received epi-off treatment of the standard 9 milliwatt per centimeter squared for 10 minutes, giving an overall energy of 5.4. This is just to show you the example of how the 3 circles are made, with the center being denoted by the highest point on the posterior float. We did 30 eyes in each group with a minimum follow-up of 6 months. This was the baseline data where both groups were well matched for age, spherical equivalent, best corrected visual acuity, Kmax, and the thinnest pachymetry. We ensured all patients had a corneal thickness of above 400 microns. In the customized cross-linking group, when we looked at the improvement in the IS asymmetry from the superior to inferior, we had an excellent regularization which was statistically significant. There was a significant flattening in the K-mean and K-max. There was a good improvement in the BCVA as well, almost approaching statistical significance. Now, this kind of improvement was not seen in the regular cross-linking group. As you can see here, in the IS asymmetry, K-mean, K-max, and BCVA were not significantly better in the postoperative period. These are few case examples. As you can see, the IS asymmetry has actually come down from 7 diopters to just 1.2 diopter. There is again almost the cone has disappeared in this particular case after customized cross-linking, and also you can see here within the visual axis, the 3 millimeter zone, there's a much better regularity. There was also, when we looked at the change in the curvature, in the initial 1 month, though they were similar, the customized cross-linking group continued to have improvement up to the initial period of 6 months, and then it flattened out over the course where we now have almost a year's follow-up of all patients. The amount of flattening of the Kmax was also significantly better, with more patients achieving 2 or 3 diopters of flattening in the customized cross-linking compared to the standard cross-linking group. An intergroup comparison was also done, where we saw the regularization, the IS asymmetry improvement, the Kmax, K-mean flattening was all significantly better in the customized cross-linking group. The demarcation line was also deeper in the customized cross-linking, and as you can see here, it was available in 3 different levels, the deepest being in the center, a patchy mid-peripheral zone, and the most peripheral zone being the most superficial, corresponding to the amount of energy delivered in the cornea itself. Safety was definitely a concern, as we are now delivering a higher amount of energy over a thinner part of the cornea, but we measured the endothelial counts pre-op and at 6 months baseline, and it was very much stable, and the haze formation was also comparable to that of the standard cross-linking group. We compared our results with already previously published literature. The issue with the previously published literature was the variable patterns gave rise to a lot more variability in the amount of results from patient to patient. So that is why in this particular study, we went in for standardized concentric circles of 3, 5, and 7 millimeter, and we showed that we could achieve better and more consistent results across the entire cohort. So with predictable patterns, we were able to give predictable results, which augured for better refractive and keratometric outcomes, and possibly the future of doing customized cross-linking with custom topo-guided treatment might even help in further augmenting the results. Thank you so much for your patient hearing.